Good evening. Welcome and thank you for registering for our webinar, Understanding Type 1 Diabetes Risk Detection, and the Emotional Impact. And this evening has been made possible by an unrestricted educational grant from Sanofi Canada. My name's Lori Berard. I'm a nurse and a diabetes educator that I've worked in diabetes for quite some time, about 39 years, and I'll be your host and discussion facilitator today. Today is our second of a three-part webinar series featuring healthcare professionals who are discussing risk detection and emotional impact of type 1 diabetes. So a few little housekeeping details for you. So we will leave time at the end of this evening's presentation for questions. That's actually what we really want, is to hear from you. So you can do that by either submitting your questions in the question and answer box or in the chat box. I'll monitor both of them. You can put them in there through the webinar. Just as a reminder, we're going to answer general questions. We obviously can't give any one-on-one personal medical type of advice, but we can sort of tell you what the recommendations or the guidelines are around this topic. So we'll be able to do that at the end. We'll have a conversation, Dr. Wiseman and I, for about 20 minutes, and then we'll try to leave about 10 minutes for Q&A at the end. As a reminder, all of the webinars will be recorded and are available at the Diabetes Care Community website for future viewing. And also, if you want more information in general, that is a great place. There's just been a whole bunch of articles written on the on type 1 diabetes screening, detection, and understanding of what's happening and all of this great new science that we're coming out with. And at the end of our session, we will be sending out an evaluation to you, asking you about how you felt about the webinar. And those are really important to us. It's really something we want to hear because it helps us guide what we're going to do in the future. So we're going to get started. And if I can move on to the next slide, I've told you a little bit about myself. I'm based in Winnipeg. The reason I'm excited to be here as a nurse is that in my career, I've had an opportunity to work in the area of screening in type 1 diabetes and some potential interventions over that course that 30, almost 40 years. But things are very different. And that's why I'm really excited to introduce our speaker for this evening, Dr. Alana Wiseman. She's an adult endocrinologist and researcher in Toronto, Ontario, and her clinical practice focuses on adults with type 1 diabetes, and her research focuses on improving outcomes for adults living with type 1 diabetes. And I've had the opportunity to work with her a few times. I know this is an area that she's passionate with and she has been the author of some of those articles on the website. So I really recommend that you go and check them out. So if we could move to the next slide, I'm going to ask Dr. Wiseman to talk a little bit about what we're going to cover tonight.
Hi, thank you so much for the kind introduction, and looking forward to speaking with you all tonight. So today we're hoping to cover the purpose of type 1 diabetes screening and what it can reveal, who should consider screening and how screening is done, how to interpret and act on screening test results, and then we'll touch on screening access and pathways in Canada.
Excellent. So this is the second part of this series. And yesterday, Dr. Lam and I had a great conversation about the risk, autoimmunity, antibodies. So this is perfect because there was a lot of questions about now what can I do and how do I get it done? So let's talk a little bit about what is the screening test in general.
Yeah, so I think it's helpful first to speak about what a screening test is, and then I can get a little bit more into the specifics about screening for T1D or type 1 diabetes. So a screening test is a test that is done to identify generally risk of developing a condition or a disease, but it's not used to diagnose the disease as if it has already occurred. And you might be familiar with some types of screening tests that are done fairly commonly. So one big example would be newborn screening. So everywhere in Canada, they typically do a heel prick test to draw some drops of blood from newborn babies, and they're screening for a whole variety of conditions that could be present in a newborn that might otherwise be difficult to identify. And then other common screening tests that might be well known are cancer screening. So, for example, mammograms to screen for breast cancer, or there's prostate blood tests to screen for prostate cancer. And so these are tests that are designed to pick something up at an earlier state before it's gotten so advanced that there would be any symptoms. So when we think about type 1 diabetes, the main screening tests we're talking about are blood tests for those antibodies. So it sounds like those were discussed yesterday evening. But there are commonly four antibodies that indicate an autoimmune process that we know is the fundamental issue in type 1 diabetes, where the body is producing these antibodies that mistakenly attack the insulin producing cells in the pancreas. And this is a process and a pathway that develops over time. So the idea with screening is that we can identify those antibodies before somebody actually has elevated blood sugars or symptoms associated with type 1 diabetes. So typically the screening test would involve testing for ideally a combination of these antibodies, so commonly four.
So a little bit about that, yeah, and we did touch on this briefly yesterday, and it was interesting because some of the people that we had on the call yesterday had some familiarity with some antibodies. So right now in Canada, how is screening actually done? So obviously this is not for diagnosis. I think that's really important. It's like is we're just screening to see if you're at risk. So it was interesting yesterday that some people had that knowledge, but many people were just asking mostly about how do I get screened? How's it done? What does that look like? So maybe you can walk us through that.
Yeah, and I'll start off by saying that I think this is a really rapidly developing area. So I think we're in this
Mhm,
time where we're going to see this becoming much more common than it has been even up until, let's say, last year.
mhm.
So I think, up until kind of now, the most common method for screening in Canada was probably through research studies for people who have family members affected by type 1 diabetes. So there is this big study called TrialNet. It's international, and there are hospitals in Canada that participate and offer. They had been offering screening through this kind of research network for many years, specifically for family members of someone affected with type 1 diabetes. As I mentioned, screening is now evolving, and so it is possible to access screening outside of the research setting. And usually, the first step to access that would be speaking with your primary healthcare provider, so physician or nurse practitioner, to see if that's an option for someone. There are some countries that have recently started screening everybody. So they generally in childhood are trying to get most of the children or all of the children in a specific area or country screened. We're not quite there yet in Canada, but this is an area that researchers are looking at as well. So that's why I said I think we're in this time where things may change quite significantly. And then I'll just make one more point that the antibodies have been available, and they are sometimes used in other situations as well. So you mentioned some people knew their antibody results. So not in a screening context, but sometimes in someone diagnosed with diabetes, if there's uncertainty about whether they have type 1 or type 2 diabetes, these antibodies are often done in that context as well.
And we had a similar conversation, Dr. Lam and I, yesterday, and you touched upon it that it's changed in the last year. And I suggested to her that this has evolved so much in the last 5 years that we wouldn't even be having this conversation. Albeit, though, these research studies that have been sort of figuring out the antibodies and the prediction, they've been around for a long time. And I mentioned I've been around in that area for a long time. So some individuals have had that opportunity to be having that discussion through trials like TrialNet. But now it's different. And I also just want to mention that, yesterday we did have that conversation with someone on the line that was asking about, like, I don't know, do I have type 1 or type 2 diabetes? They call me LADA. And that's a great example, especially when someone's older and you're not sure if it's taken them 20 years to get type 1 diabetes or if they really have type 2 diabetes. And it is important for treatment to sometimes know which they have. So the antibodies have been available. But to now, when we're starting to talk about it, I think you're getting excited as a clinician looking after a lot of individuals that have type 1 diabetes. And we all would like to change the future. All right. We'd like to be able to offer families some understanding and some awareness. So let's talk a little bit about, screening and when it should be performed and how it needs to be followed. So we've talked about how we do it and how you might access it, but like tell us about screening and then what happens.
Yeah, so I think right now, in terms of who should access screening, we're probably prioritizing people who have a family history of type 1 diabetes, so a first degree or second degree relative with type 1 diabetes, or possibly people who have other autoimmune conditions. So we do know that, unfortunately, someone with any autoimmune condition, it is a sign that there's some dysregulation of their immune system. It does mean they're higher risk for other autoimmune conditions as well. So, for example, with type 1 diabetes, we commonly see autoimmune thyroid conditions. So, those would be another kind of category of people where it might be reasonable to do screening for type 1 diabetes. As I said, I think we're in Canada, we're not quite at the level of screening everyone in the entire population, but that is an area that's being considered and studied in terms of what that would look like.
But for someone who's listening today and they're wondering about this, if they sort of fit into this criteria, this would be a conversation they should be thinking about having with their healthcare professional. And I sort of took you a little bit out of order, and I want to come back to, after you've been screened, what do we do next? But let's let's talk a little bit about the age. So this question came up yesterday, and you mentioned newborn screening, and we know that children can be diagnosed with type 1 diabetes under the age of 2, or they can even be diagnosed in the first year of life. And I mentioned sometimes people are diagnosed when they're in their 50s and 60s. So let's talk about age for screening.
Yeah, so generally screening is ideal to be performed at a younger age, so under age 15, because that will identify most people at the time in their life when they're most likely to develop these antibodies. Of course, that's not an absolute. So older people can develop antibodies later on. But if we're talking about screening, generally the studies have suggested kind of three age categories, and they're all at quite young ages. So ages 2 to 4. So you mentioned the under 2. We don't generally see a lot of type 1 diabetes, so we're waiting for that age 2 to 4 as a time when these antibodies will emerge. If screening is positive at any point, we always want to follow. I mean, it's kind of getting at what you said. We'll get back to, but you always want to follow up with a second test to confirm it's positive. And we can get into a little bit about one versus two or more antibodies. But you first want to confirm it's positive. And at that point, if you've confirmed it's positive, then there's no point of repeating screening because you've done the screening test, it's positive. So now you move on to surveillance, which we could talk about as well. If the screening test is negative, then that's reassuring at that moment in time, but it doesn't guarantee that there can't be development of autoantibodies later in life. And so, particularly if the screening is done at that ages of 2 to 4, for example, then it might be repeated at subsequent age categories. So, generally, ages 6 to 8 is kind of the next common window, and then ages 10 to 15. And as I mentioned, most people who will develop autoantibodies do develop them before the age of 15.
And so, in the individuals, and this is a question more for me, in the individuals that you talked about who should be screened, if they have a negative first test at these age, does that sort of mean that they'll be advised to come back between 6 and 8 for another test and at 10 to 15? And then perhaps after 10 to 15, if it's still negative, that they may not have screening later in life, or we still need to determine later in life?
Yeah, so I think there's still, research being done in this area, and a lot of the research has focused on children, so we don't have as much research to
Mhm.
know, what this means for adults as opposed to children. So I think if they're at higher risk, for example, because of a family history or another autoimmune condition, and that's what prompted the screening in the first place, if that test comes back negative, I think it would be offered to repeat it at these subsequent time periods.
And I think we're going to see that more protocolized as we get better at this because it is relatively new. So let's talk a little bit, let's move to talking about the screening results when they're positive. So understanding the results. So what does that positive screening test mean after it's been done a second time, obviously?
Yeah, so a positive screen for type 1 diabetes generally would be two or more antibodies. That's when the risk for developing type 1 diabetes is really so high that it's essentially almost an inevitability that that person is going to progress on that pathway to type 1 diabetes. So, for all purposes, I would say a positive screening test is two or more positive antibodies. So what should one do if they get that result? Well, hopefully they're receiving that result with some education and some counseling. It might involve referral to a specialist who's able to provide more of that education and counseling in detail. The next step would be wanting to confirm that they actually don't have clinical diabetes at that point. So that would involve assessment of their glucose levels, and commonly that would be a fasting blood test, an A1C test. So that's a non-fasting assessment of blood sugar levels. It might include a glucose drink test, the 75-gram oral glucose tolerance test. And more, we're actually starting to use continuous glucose monitors as well in this scenario to have an understanding in detail of what someone's glucose levels are doing. So we would want to first ensure that we do all that and that the person isn't meeting criteria for
Hmm.
diabetes. If the sugars are still completely normal, then that's something that we would call stage one type 2 diabetes. So the antibodies are present, but all of the glucose tests are looking completely normal. Those are people who need to be monitored, again, because they'd be considered very high risk for developing type 1 diabetes. So that would mean ongoing monitoring with assessment of blood glucose testing at some interval. And it can get a little complicated because it depends on the age of the person, how often that interval might be. But somewhere between every 3 to 12 months, like in that time window. The other possibility is that there could be actually some mild glucose abnormalities that don't, again, meet criteria for type 1 diabetes, sorry, but put them in this stage 2 type 1 diabetes category as opposed to stage 1.
So I guess the takeaway here is that if someone has had access to doing screening and they know what they have in terms of the number of antibodies, so two, they should be in some type of programmed care, that they've been given the education, that they've been educated about symptoms, that they're being monitored, that they have access to a specialist. And that's what we're working with this idea of bringing this to the population. And what about when the test is negative and I think I kind of asked you this, but again, it's negative, and the other question I'd like you to answer is negative or just one, what happens?
Yeah, so that's a bit of a different scenario. So I'll start with the one antibody because we haven't touched
Okay.
on that yet. So one antibody, there is an increased risk of developing type 1 diabetes, but it's not that really high risk we see with two or more positive antibodies. So most people with one positive antibody actually they're more likely to not develop type 1 diabetes than they are to develop type 1 diabetes. So that's a more challenging situation, and it also depends on age and which antibody it is. So it can get quite complicated because certain types of antibodies, even if if that's the only one that's positive, might be higher risk than another type of antibody. You still want that education, counseling, and monitoring. And time is also very important in that situation. So if it's a positive antibody, there's a chance it actually can go back to being negative later, versus it stays positive, and then you're looking to see is another antibody going to
Right.
become positive
Okay.
later. So I think time really helps clarify those cases. So it's
Okay.
important to have the monitoring.
And the negative, if they're screened and they're negative?
Yeah, so I think generally that should be taken as kind of reassurance, but again, it's not a guarantee because we
Yeah.
are looking at these antibodies that can change or develop later. It's not a guarantee that they're, completely 0% chance of developing type 1 diabetes. So I think generally reassurance, but consideration of potentially repeating depending on the
Screening.
age of the person.
Right. And the ages that we talked about. And we're going to learn more, as you said. And it's very true. We've been screening primarily children or young adults. So we don't have a lot of information beyond those years. And so we'll learn as we go. And so, this has been great, but right now, how can Canadians be screened if they meet that criteria? And you mentioned the TrialNet and you mentioned you mentioned the provider, but what can that actually look like? Like, how can they find TrialNet, or what should they say to their provider?
Yeah, so I think TrialNet, if you just, search TrialNet on Google or whatever search engine of choice,
Hmm.
Canada, you should be able to access their website. And I believe it can be done like mail-in testing
Yeah,
for
that was my
antibodies. So
question. Yeah.
it's quite accessible. Um, so that's in the context of the research study. And then also there is the opportunity then if someone screened positive and they did it as part of TrialNet, there is the opportunity to then potentially participate in research studies if there are therapies that are being, tested to prevent or delay type 1 diabetes. Um, Otherwise, then I would go to the primary care provider or physician, perhaps with some information that you've printed or looked at and said, I'm higher risk for type 1 diabetes because of this, and I'm interested in screening with antibodies, and kind of going from there.
And they might just say, "Hey, I got to listen to Dr. Wiseman and Dr. Lamb, and they talked a lot about, who should be screened, and I would like to have some more information about this as well." Great. So I'm just going to stop us there because we're at about 20 minutes, and I do have a question in the question and answer box, and I'll open that and see. Okay, so the question that's been asked is, right now, and we had this question yesterday, Dr. Wiseman, just to put it into context if people were on both days, is it covered by OHIP? And you're perfect because yesterday you had Alberta and you had Manitoba, and today we have an Ontario-based physician. And so it's the is any provincial government covering it? And we felt that the answer was no for screening, not for diagnosis, as you mentioned. That should be covered in different provinces in different ways. And but what about if someone actually wanted to be screened? Is there a route that they could pay to do that?
That's a good question. I think, interestingly, when we order antibodies
Hmm.
on patients, at least in Ontario, there is no we don't indicate whether we're doing it to, for diagnosis or for screening. Um,
Hmm.
uh, but the antibodies are not covered in Ontario regardless.
Okay.
If you're seeing physicians at a hospital, sometimes the hospital budget covers all the tests that
Okay.
are done at the hospital. So that might be a way to access it without testing if it's done through a hospital.
And I think one of the other things that's interesting about the testing that's done, and we talked about this a bit yesterday about, it's different provincially in terms of, what people can access, but even who can order the test is different. So I know for us in Manitoba, they can't get all four. They can order two, but they can only be ordered by endocrinologists. They can't go to a primary care provider and get that for the sake of the diagnostic criteria. So we have a lot of development in this area that still is going to need to happen before people are going to be able to just walk in and get this done, even if they're willing to pay out of pocket. But I think it's really important that you said they can Google TrialNet and they can get the information there. And there are not TrialNet sites in every single corner of the country, but it seems that their reach is now so that if you're interested, they're going to facilitate helping you be screened. And that's a win-win situation because we only have the research and the information to be able to present this type of stuff when people participate. The win-win is that we get more information and the individual gets screened. So it's really a win-win if this is something that people listening to are really wanting to have done, is that TrialNet is an option that's open to everyone who meets the criteria. Um, and there's just a comment again around family doctor in Alberta, same thing, to get an antibody test that had to be sent to an endocrinologist as well. And I guess the other thing I just before we sort of end our time together and is that there's the question about staging and antibodies versus genetic risk. And is it interchangeable, or is there something we need to talk about a little bit differently?
Yeah, so there are some genetic risk scores that are being used in research studies as well. So we know for type 1 diabetes, the development is complex. So there's an immune component, but there is also a genetic predisposition, and that's why we see a higher risk in family members of someone with type 1 diabetes.
Hmm.
I don't believe anyone anywhere in the world is really doing these genetic scores yet as a screening test. So that may be an area in the future. They are using them in research studies right now. So they're looking at someone's genetic risk for type 1 diabetes, but really the screening tests we're talking about today are reflecting the immune system process as opposed to the genetics.
Good. And I think there's another question, and I don't know this answer. I'm hoping maybe that you do, and I should probably know the answer to this question. But currently, is there an age limit for people in TrialNet to participate in terms of screening? Is there an upper age limit
Yes, and I believe it depends on the relative. So
too?
everyone for TrialNet has to have a family member affected with type 1 diabetes. I think the oldest age they'll do screening for in TrialNet, I believe, is 45.
And you
Um,
have to be first degree, I think, for 45.
yes, I believe so. And then I think there
Yeah.
is a younger age limit if it's a further degree relative. So you can still access TrialNet for screening with a non-first degree relative, but I think the age cutoff is lower.
I think it's 20. It used to be 20 if it wasn't a first degree relative. Oh, 22. Thank you. Somebody answered it for us. 45 for first degree and 22 for second degree. So it's been great. Yesterday was a little bit about understanding the autoimmune response and why this happens and the triggers, once we know that people could have higher risk and the triggers. And then we talked a little bit about the antibodies. And today was a very practical discussion around who, why, how, and when. I love the when. So thank you for like going through that with me because these are things that I think for people to understand that, screening is not always one and done. It too is pretty definitive. You're going to be in a pathway, but it's confirmed too. So you should never be treated on just one screen alone. It should always be a second one that confirms, but two is definitive and you should be in a pathway. That there could be a discussion that individuals, thanks. So I'm getting second is 20. So it's 20 for second and 45 for first. That you should be in having a conversation and you should be in a pathway if you've had this screening done. If this is something that's really interesting to you for your family, that you can start the dialogue either with TrialNet or start talking to your primary care provider. Things are going to change rapidly, so stay tuned to this space because we're going to push out more information. So that's a little bit of what I take away. Is there anything that you would like to leave the individuals who've been with us today in terms of your key takeaways of what they'd like to have from today's session?
Yeah, I think as you said, this is a really this is an evolving space, and I think I hope that people consider screening and that they access resources. I think what we don't want people to be doing screening tests and not having any information or counseling around the results of that. So I think really accessing through TrialNet or through the healthcare provider, or even asking for a referral to a specialist, like an endocrinologist, if the primary care provider is not able to answer. I think we just really want people to be informed about these results. And as I alluded to, it can be quite complicated and individualized based on so many factors, like someone's age,
Exactly.
how many antibodies, which antibody. So I think this is an evolving space and hopefully will become somewhat simpler. But I just want people to have access to support and resources.
And the things that we talked about yesterday was the biggest reason for knowledge is to prevent medical outcomes that are not favorable. So if we know that this is risk and they've been educated and they're monitored, we can prevent, horrible outcomes of, severe episodes of diabetic ketoacidosis on diagnosis. And that, in fact, that one of the other things that we talked about yesterday is that the reason that we're able to have these conversations, so much research has been done in this area. We're much more confident in sharing this information about antibodies and staging, but we also know that there's evolving therapies that may be accessed in the future. And so we can provide some hope around understanding if there's something that can delay the progression to the diagnosis. So with that, if I could get you to put the last slide up for me today, I just want to thank Dr. Wiseman for a very eloquent and simple explanation about who should be screened, how they should be screened. I want to remind you all that an evaluation will be sent to you about today's webinar, and it's really important. If you want to review this webinar, you can access on the Diabetes Care Community website. And if you want any more information, as I said, I'm going to plug you again, Dr. Wiseman. Your articles around this whole topic that have been posted on Diabetes Care Community are so amazingly well written, and there's so much great information in there. And that's the type of stuff that people really can, sink their teeth into, because it's written for people who are very interested in this area because of their families. So thank you for doing those articles as well. I want to thank the people in the background that supported this Diabetes Care Community, and most of all, Sanofi, for giving us the opportunity to spend this half an hour with you. So I wish everybody a wonderful remainder of their evening. And I've got to say it again, go Canada, go. We've got still some medal hopefuls in the Olympics, and let's hope we finish these games strong. Thanks, everyone. Good night.
Bye. Thanks, everyone.